So we're going to look for potential ductal utilization. When we see stones within the gallbladder or those echogenic foci, we want to assess for mobility. So we're going to decube patient. We're also going to assess for sonographic Murphy sign. I'm not sure if this is something that they ever mentioned to you, but this is something that we would do in our ultrasound labs. We would, if a patient had gallstones, we assess for sonographic Murphy signs. We did it regardless whether or not we saw stones, but we'd have the patient take a deep breath in and we'd apply a pressure over the gallbladder and see if we can elicit a pain response. Like either the patient, takes a breath in, all of a sudden a gasp, or they're like, ow, 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 So that's what's considered a sonographic Murphy signs, and that could be an indication of acute cholecystitis. So a positive Murphy sign could indicate cholecystitis. So a lot of my reports, I would include positive or negative Murphy sign. So these echogenic foci, they may exhibit shadowing if they're calcified. They may also exhibit Twinkle Artifact. So those are some of the other things we look for. So look for shadowing and Twinkle Artifact. So Twinkle Artifact, that's when we put our color Doppler box over the calculus or the stone or that echogenic foci. And the color starts going all crazy. So we get like this really aliasing speckle over that stone or that echogenic foci. And if you're ever not certain, if it's really Twinkle Artifact versus just regular artifact, or potentially even like maybe a small vessel that's maybe along the gallbladder wall, if you put your spectral Doppler and try and get a spectral tracing of that Twinkle Artifact, it's just going to go berserk. It's going to just be this loud static sound that's just so that you'll know 100%, yes, that is Twinkle Artifact. And you can even take a picture of that too, just to confirm, like, boom, yep, this is Twinkle Artifact. Here's a spectral tracing of it. It goes bananas. It's like off the charts. So diseases required in hereditary diseases. So some hereditary diseases may predispose an infant or child to developing certain cancers. So one of those diseases is going to be our, I'm butchering this, Beckwith-Weidman syndrome. Syndrome. And this causes an increased risk of hepatoblastoma. Chronic condition. Like cystic fibrosis. Has a high association with chronic pancreatitis. Association with chronic pancreatitis. If you remember back to before, we mentioned that pancreatitis can have a high mortality and morbidity in young children. So, Biliary disease. Now, liver disease. We can have an example of hepatobiliary disease would be a fatty liver. So obesity. So obesity is going to be one of the main causes that may lead to non-alcoholic hepatocytosis. Main cause of alcoholic That's just a fancy way of saying fatty liver. I mean, I've seen this quite a bit in the clinical setting. I've definitely encountered quite a few children, 6, 7, 8 years old, and they're very obese, and their livers look like a liver of like a 60-year-old, 70-year-old patient, very echogenic, very hard to scan through. You see very poor portal definition. So sonographically, there are 4 general categories of fatty liver classification. There's absent, none, and then we break it down to mild, moderate, and severe. Classified. Moderate. Severe. So liver appears echogenic when compared to kidney. Liver enlarged. With loss of portal visualization. The liver is going to appear echogenic when you compare it to the kidney. So when we do that right kidney liver comparison, liver is going to look much brighter. It's going to be typically enlarged. You're going to have loss of that portal triad visualization. So it's going to be more difficult to visualize the portal vessels coursing through the liver. It'll appear a little more heterogeneous. So another hepatobiliary disease. We can have cirrhosis and portal hypertension. I just abbreviate hypertension, HTN. So the cause of cirrhosis in children is often divided into 4 categories. So the first category is biliary. So we're going to put over here causes of cirrhosis. The first cause is going to be biliary. So some examples of biliary causes would be biliary atresia. So essentially that's lack of formation of a gallbladder. Under here, we can also have a condition called Alagille syndrome. ALAGILLE. Under another biliary cause, cystic fibrosis. We mentioned cystic fibrosis affects the pancreas, can lead to chronic pancreatitis. So that CVD has to now pass through that head of that pancreas. So cystic fibrosis and the cause of the pancreatitis could potentially constrict that duct as it's passing through the head of the pancreas, causing biliary disease or biliary cause of cirrhosis. Second cause would be metabolic. So example of that is Wilson disease. Third cause is post-necrotic cirrhosis. So this is something that could potentially happen in utero, or if a baby gets infected by a virus. So this could be post-viral. And neonate. Or autoimmune. Hepatitis. And the fourth would be unknown causes. So sonographically, this disease displays the same in adults as it does in children, such as abnormal liver surface with increased echogenicity and nodular changes. So this is going to look, it's going to have the same clinical presentation as cirrhosis would, as cirrhotic liver in the adult population. So appears. I like to use the term fibrotic. So it's echogenic. Nodular. Heterogeneous. Another hepatobiliary disease could be cholangitis. So this is an infection of the biliary tract that can occur in children and is often associated with congenital or immune-related biliary abnormalities and immunodeficient states. So cholangitis is an infection of the biliary tract. Infection of biliary tract. Associated with genital or immune related biliary abnormalities. So it may also result from surgery. So the infection may arise post-surgery, as in correction of biliary atresia or liver transplantation. Also result post most often bacterial. But may also be fungal or viral. Or even parasitic. So cholangitis is inflammation of the biliary tract that occurs in children, and it's often associated with congenital or immune-related biliary abnormalities. It can potentially also result post-operative for surgeries that may correct certain biliary conditions like biliary atresia, or even potentially in a liver transplant. And it's often bacterial in nature, but may also be fungal, viral, or parasitic. So cholangitis, primary sclerosing cholangitis may have inflammatory bowel disease. Progressive cholestatic disease may result in cirrhosis, portal hypertension, and ultimately liver failure. So disease progresses may cirrhosis, portal hypertension, and eventually, and even liver failure. So on ultrasound, we're going to look for intra and extrahepatic ductal dilatation. So on ultrasound, look for intra and extrahepatic ductal dilatation. And any signs of cirrhosis. Also assess for splenomegaly. Pancreatic disease. So under pancreatic diseases, we're going to place cystic fibrosis. So cystic fibrosis is an autosomal recessive disease involving abnormal chloride metabolism, which often affects exocrine glands, i.e. sweat glands, pancreatic exocrine glands, leading to increased viscosity. Cystic fibrosis frequently affects the biliary epithelial, resulting in end-stage liver cirrhosis and pancreatic atrophy. Fibrosis is a autosomal recessive disease. Which affects exocrine glands, pancreas being one of those exocrine glands, usually affects biliary epithelial tissue resulting end stage liver disease or liver cirrhosis. Atrophy of pancreas. Atrophy of pancreas. Of pancreas. Splenic diseases. So main thing we're going to be looking for is splenomegaly. So maybe seen in children affected with diseases like mononucleosis in patients. Nucleosis. As well as sickle cell disease. Leukemias. Lymphomas. Liver cirrhosis. And a disease called cat scratch fever. Cat scratch fever or cat scratch disease. It's a bacterial disease. This is a bacterial disease. Oh, sorry. Disease. Spread by cats when a child is scratched or bitten. And it often appears within 1 to 2 weeks following the incident. So bacterial disease spread by cat scratch or bite. And it's accompanied with fever and lymphadenopathy. fever, and enlarged lymph nodes, so lymphadenopathy. All right, so where's this? So neonatal jaundice. This is something that we encounter quite often in the clinical setting, especially anyone that's been to any neonatal intensive care units. You see the babies under the UV lights getting ultraviolet treatments to help correct neonatal jaundice. So it's persistent jaundice. It's defined neonatal jaundice as persistent jaundice beyond 2 weeks post-delivery. So this is jaundice. Beyond 2 weeks. Post delivery date. Is abnormal. So sonographic evaluation, however, may differentiate between obstructive versus non-obstructive jaundice. So ultrasound is used to differentiate between obstructive non-obstructive jaundice. So again, ultrasound, we know there's no radiation involved, so it's the imaging modality of choice for pediatric patients when we're trying to limit radiation exposure. So we can use the ultrasound to determine whether the cause of the jaundice is an issue from an obstructive process, say like a mass or a tumor compressing the bile duct, or a mass within the liver, or a non-obstructive source like a cirrhotic liver. So in cases of bile obstruction, biliary atresia, or metabolic diseases is important. The neonate is treated early before cirrhosis occurs. So a diagnosis must be made soon after delivery. So early diagnosis. Important to prevent development of cirrhosis. Furthermore, jaundice may be caused by either an extrahepatic or intrahepatic obstruction to bile flow. Obstruction. Either intrahepatic or extrahepatic. So some extrahepatic. So extrahepatic causes. Obstruction. You have biliary atresia. Choledocal cyst. Spontaneous perforation of CBD. Choledocal Cyst. Gallstones. So intrahepatic causes could be hepatitis and metabolic diseases. There could also be systemic diseases that cause cholestasis. So some cholestasis is when the gallbladder fails to contract. So that can include heart failure, shock, sepsis, neonatal lupus, or severe hemolytic diseases, like a severe sickle cell crisis. So ultrasound may be ordered to differentiate among the three most common causes for neonatal jaundice. So out of the ones we've mentioned so far, three most causes. Neonatal jaundice, number one, it's going to be hepatitis. Number two, it's going to be biliary atresia. Number three is going to be choledocal cyst. So with each of these conditions, the liver appears coarse and echogenic on ultrasound. Various other conditions such as hepatic inflammatory, obstructive, or metabolic process have a similar sonographic appearance. Liver appears echogenic and coarse. Coarse and echo texture. So neonatal hepatitis. So infection of the liver that occurs within the first 3 months of birth. Liver. And first 3 months. There are a number of causes of neonatal hepatitis, and they include infections. So causes include infections, metabolic disorders, familial recurrent cholestasis. Metabolism errors. And idiopathic or unknown causes. Idiopathic. Neonatal hepatitis. Liver may be normal sized or enlarged. Liver be normal size or enlarged. Here's hyperechoic, hyper, with decreased visualization, portal venous triads. Biliary ducts and EB are not enlarged. We're not going to see our intrahepatic biliary ductal dilatation. We're not going to see that. We're not going to see an enlarged gallbladder. So if the hepatocellular dysfunction is severe, the gallbladder may actually be small in size because of decreased production of bile. So if disease is severe, GB may appear contracted due to low bile production. So biliary atresia. So biliary atresia is a narrowing or underdevelopment of the biliary ductal system. Narrowing or underdevelopment of biliary ductal system. Biliary atresia may affect the intrahepatic or extrahepatic ducts, or may not involve the gallbladder, although the latter is the most common form with absence of the gallbladder. So may affect let's see, intrahepatic or extrahepatic ducts, biliary ducts. And may also affect GB, gallbladder, with an absent GB being a common presentation. So the couple of patients or kids that I've encountered with biliary atresia, they didn't have a gallbladder. I'm looking and searching and searching. I'm like, this doesn't make any sense. Like, I'm asking the mother, when was the last time, you fed this baby? When was the last time they ate? Oh no, it's been hours. It's been 2, 3, 4 hours. And I still don't see a gallbladder. So that should raise some red flags for you for the presence of biliary atresia. In patients that do have biliary atresia and they do have a small gallbladder, we'll image the patient and then we'll get them back. We'll make sure that they're NPO for at least 2 hours and re-image the gallbladder, and you'll essentially see no change in the size of the gallbladder. You'll see a small little teeny tiny gallbladder. They'll come back, 2, 3 hours later, having been an NPO for certain, and you'll re-image them and that gallbladder will essentially look unchanged. So clinical features of biliary atresia in the neonate include persistent jaundice, acolic stools, dark urine, and abdominal and distended abdomen from hepatomegaly. So with biliary atresia as well, liver might be normal in size depending. Can also appear enlarged. The echogenicity of the liver parenchyma may be normal or increase slightly with slight decrease in visualization of the periportal venous vasculature. So this would be more in the late stages or later, an older infant with biliary atresia diagnosis, where cirrhosis is starting to set in as a result. So if it's early in the diagnosis, the liver is more likely going to appear normal in size and normal in echogenicity. Whereas with the hepatitis, we get an increase in echogenicity. The hepatitis will have increased echogenicity. Biliary atresia, we typically will have a normal echogenicity. So ultrasound. Normal echogenicity. Unless fibrosis is beginning So unless they've had the biliary atresia for an extended period of time and the liver is becoming fibrotic, that's when we'll begin to notice increased echogenicity. Unless fibrosis is beginning, then echogenicity will increase. So as the liver becomes more fibrotic and more cirrhotic, the echogenicity is going to increase. And as fibrosis begins to set in, we're going to lose that visualization of our portal venous vasculature. So with biliary atresia, a small hyperechoic focal triangular area is often referred to as a triangular cord sign, may be seen anterior to the portal vein bifurcation on an oblique transverse view. I'll show you guys, write that down. Small hyperechoic focal triangular area seen anterior to portal bifurcation. Which is fibrotic remnant of the biliary structure. So if we're imaging our liver and we're in sort of an oblique view, coming intercostal, I like to do that for visualizing my main portal vein coming into the liver. We'll get our bifurcation of the main portal vein into our right and left. So anterior to that bifurcation, you're going to see this echogenic triangular structure which may represent the fibrotic remnant of potentially the gallbladder. So that's one way to diagnose biliary atresia. So this is referred to as a triangular cord. Triangular cord. This is the hypoplastic fibrotic remnant. I'm going to turn to in case you encounter hypoplastic fibrotic remnant of biliary structure, which is seen anterior to the portal vein bifurcation. So a normal size, again, this is still biliary atresia. So a normal size gallbladder may be seen with an atretic CBD or common bile duct is distal to the insertion of the cystic duct. A normal size BB seen with atretic. So atretic, that means severely diminished size. We describe something as atretic. So atretic CBD, common bile duct. So we have an atretic area, an atretic CBD distally. Distal to insertion cystic duct. So however, if gallbladder is present with biliary atresia, is often small, is often the small pseudo gallbladder that appears as a fluid-filled structure less than 15 millimeters in length within the intralobar fissure region and often without a normal gallbladder wall. So with gallbladder is present. It's often pseudo GV, pseudo gallbladder. So measure less than 15 millimeters in length. And does not have a normal GV wall. So essentially, this is just going to kind of look like an anechoic fluid collection, a small little fluid collection, that's within the interlobar fissure of the region. So it's going to be in the area where your gallbladder typically would be, but it's not going to look like a normal gallbladder. It's not going to have the normal gallbladder wall appearance. It's going to be very small, only less than 1.5 centimeters in length. Like I said, it's not going to be able to contract and expand like a normal gallbladder would, because it doesn't have that wall, that muscular wall that allows the gallbladder to contract. So these babies that you're suspecting, agenesis of the gallbladder and biliary atresia, we're gonna do our imaging. We'll have them come back, 2 hours later after being NPO, re-image in that area, that pseudo gallbladder will essentially look the same. So under biliary atresia, a change or decrease in gallbladder size after milk feeding can suggest patency of the common hepatic and common bile ducts, and is seen only in neonatal hepatitis. So like I said, if we're imaging the gallbladder and then we had a change in size, then we have patency of the hepatic, and common bile ducts. And this change in size is only seen in neonatal hepatitis. Third main cause of neonatal hepatitis is our choledocal cyst. So a choledocal cyst is an abnormal cystic dilatation of the biliary tree, and most frequently affects the CVD. So choledocal cyst, abnormal. Cystic dilatation. Biliary most commonly seen CVD, common bile duct.
Dan, can you readjust the camera?
Sorry.
Thank you.
You're welcome. So choledocal cyst, this is abnormal cystic dilatation of the biliary tree. And this most commonly affects the common bile duct. There are 5 types of choledocal cysts, with type 1 being the most common. So, types. Type 1 most common. Type 1. So type 1 is a fusiform dilatation of CBD. Type 2 is one or more diverticula of the CBD. One or more. CBD. Type 3 is dilatation of the intraduodenal portion of CBD. So, dilatation. Intraduodenal. So this is also referred to as a choledocal seal. Choledocal seal. Type 4 is dilatation of the intrahepatic and extrahepatic ducts. Intra, extrahepatic ducts. And type 5 is Biliary disease with dilatation of the intrahepatic ducts. Dilatation. So with choledocal cysts, neonates present with jaundice and pain. And there may be a palpable mass in the right upper quadrant. And with vein. Operable mass, right upper quadrant. So ultrasound can be used to differentiate between the presence or absence of a gallbladder, dilatation of a ductal system, or presence or absence of a mass. Oh boy, a lot more than that. All right, so it's 9:30 now. I'm going to record some more during the break and post it for you guys. So I'm gonna at least try and get through the liver tumors. So I'm gonna keep recording and just post for you guys. So you guys can take your break. I'll see you back at 10. I may have to record later in the afternoon some more of the pediatric stuff as well, just because it's a lot. This PowerPoint's actually a lot of slides. So I just want to make sure we get through everything. So anyway, I'll see you guys back in a little bit.
Thank you.
All right.
Okay, thank you.
Thank you.
You're welcome. So next topic is going to be abdominal tumors. So abdominal tumors. There we go. So pediatric abdominal masses are often differentiated based on patient's age. You know, a neonate versus young infant versus older infant versus child. And symptoms, symptomatic versus asymptomatic. Another thing to think about is usually, but certainly not always, as is the case with ovarian torsion, abdominal masses of the gastrointestinal tract are symptomatic and others are asymptomatic. In all age groups, the majority of neoplasms arise from the retroperitoneum and kidneys in particular. That's an important point to highlight. So that, you know, leads precedence to us being able to perform a very good retroperitoneal study, particularly in our pediatric patients, knowing the fact that the majority of neoplasms in pediatric patients arise from the retroperitoneal area. Pediatrics. Majority. Neoplasms. Retro. Yeah. The retroperitoneum, comma, and kidneys in particular. So what I'm going to discuss is liver tumors. So primary liver tumors, while more common in children, only account for 5 to 6% of all intra-abdominal masses and 1 to 4% of all solid tumors in pediatric population. Primary liver tumors account to 6%. Intra-abdominal masses. Children. But something to also keep in consideration, even though it makes up only a small percentage of the intra-abdominal masses, 2/3 of all childhood hepatic tumors are malignant. So, 2/3 of all hepatic tumors are malignant. So unfortunately, if you're scanning a liver and you see a liver mass, more often than not, it's going to be a malignant tumor that you're looking at. That's when you have to have that, real strong poker face, because it can be sad. So the two most common malignant tumors in childhood are hepatoblastoma and hepatocellular carcinoma. Most liver tumors hepatoblastoma. So Hepatocellular Carcinoma. Others include undifferentiated sarcoma, and rhabdomyosarcoma. Metastases to the liver may arise from metastases to the liver may arise from neuroblastoma. Underline that one. Next tumor. Leukemia. Or lymphoma. So hepatoblastoma. Hepatoblastoma. This is the most common primary malignant disease of the liver. You said most common primary malignant. It's associated with the Beckwith-Weidman syndrome. And with Beck with Weidman syndrome. It's also associated with hemihypertrophy. Familial adenomatosis, polyposis. So familial adenomatosis. Polyposis. As well as precocious puberty. That's early onset of puberty or menstrual cycle, as well as congenital anomalies. It's also associated with fetal alcohol syndrome and very low birth weight. Fetal alcohol syndrome and very low birth weight. So what does it look like sonographically? So again, there's lots of good pictures of this in your textbook, as well as on the PowerPoint slides that are provided for you to go and look at to really appreciate, what these tumors look like. So go to your textbooks, take a look at the tumors, familiarize yourself. So with hepatoblastoma, appearance. So appearance of tumor. The tumor is single. Solid. Large. Will appear heterogeneous. And complex. With small cysts. Echogenic calcium deposits. May appear rounded or irregular shape. So may see areas of necrosis or hemorrhage within tumor. Those areas will appear hypoechoic or anechoic with internal debris or septations within those anechoic areas. Another thing to also remember is that usually it doesn't show signs of infiltration, so the remaining liver will appear normal. So, remaining liver will appear normal. So other things that we're going to see on ultrasound. Intrahepatic vessels are displaced or amputated by the mass. Hepatic vessels displaced or amputated by mass. You can use color Doppler. To detect high velocity flow and malignant neovasculature. So what that means is we can put our color Doppler on, and these malignant tumors, they they're going to have their own blood supply. So they're going to form new vessels or neovascularity to supply that growing tumor. So when we put color on, we'll see increased blood flow to the mass and vessels feeding that mass. And within those vessels, we'll detect high velocity flow, which will also be low resistant. That's another thing that typically you'll see. So you'll see high velocity, low resistant flow within these new feeding vessels to that mass and that neovascularity. Calcifications are common. Which will also be low resistant also. All right, so the second most common primary liver tumor is our hepatocellular carcinoma. So you'll often see it abbreviated HCC. So like we said, this is the second most common. And it usually affects older children over 3 years of age. Affects older children greater than 3 years. And half will have pre-existing liver disease, such as hepatitis or type 1 glycogen storage disease. Pediatric patients. Pre-existing liver disease like hepatitis, so hepatocellular carcinoma, its appearance. So this tumor is more often multicentric solid mass involving the whole liver. and is usually without calcifications and variable echogenicity. It's going to appear centric. Involving without calcifications. So if we remember with our hepatocellular blastoma, calcifications are common. With hepatocellular carcinoma, calcifications are not common. Calcifications. So with HCC, color Doppler should be used to evaluate the portal venous and hepatic structures to look for thrombus or tumor invasion. So use color Doppler to evaluate portal hepatic veins or thrombus or tumor invasion. So I'm going to stop here just because I got to jump on for our next class. And I'll be recording a little bit later. Thank you.